Fantastic. Thank you so much for your comments. And we will have an opportunity to probe them further with you in the discussion shortly when we open it up to our audience members. But I want to turn now to Dr. Abraham Verghese. Dr. Verghese comes to us from Stanford University. Many of you will know Dr. Verghese's name. He is a critically acclaimed author and a prominent voice in medicine. His gift is as a storyteller, and many of you will be familiar with his best-selling books. I'm just lifting one comment from his bio that you can find in the materials. He says he sees a future for healthcare that marries technological innovation with hands-on physical diagnosis and has a deep faith in patient stories and the power of touch in providing what patients most want, healing, if not curing. Dr. Verghese, thank you very much for being with us today, and we look forward to hearing your reflections.
Thank you so much, Andy, for that introduction. I'm delighted to be part of this symposium. I think when we talk about diagnostic excellence, we really must begin with the simplest kind of diagnosis, the one that is evident to our eyes and our senses, and ask ourselves, how well are we faring there before we move on to the more sophisticated forms of diagnosis we will be discussing today. I'm haunted by, and I'm sure many of you are, the fact that every single day in our hospitals, we have this phenomenon of patients appearing and the diagnosis being made evident to us by a radiologist, often the next day, to tell us that there's a strangulated hernia in the inguinal orifice, or that the problem that we think is in the chest is in fact in the abdomen. And we are embarrassed to find that, our diagnostic excellence in these ivory towers did not seem to include the ability to take the clothes off and inspect a decubitus ulcer or see what is clearly evident to us. So I do think that the bar of diagnostic excellence really must begin with the simplest level of being able to see what is staring us in the face and not have that be clouded by the layers of sophistication and technology that are excellent and necessary, but that are built on that first premise. Me and my colleagues have identified numerous anecdotes of oversights in the physical exam that led to consequences. It's a published study, an ongoing study, and I think as a modern society, it's humbling to look at those anecdotes. People with shingles who are in the cath lab and contrast is being injected before someone notices a dermatomal rash that looks like dewdrops on rose petals. So I think that's one aspect of things that interest me about the notion of diagnostic excellence. The other is, I think, the importance, and I think our next speaker will be addressing this more fully, is the importance of the diagnosis to the patient. The diagnosis is not our entity alone to grapple with. It really is something that is of critical importance to the patient. By that, I mean, it's important to localize the diagnosis on the patient's body. Patients have this need, I think, to have us point out to their embodied persona where this illness is. It should not exist merely on a lab slip or an image. And I've always been struck by the ability of the physical exam to simply acknowledge what is already known to us, but it still seems a necessary step to examine the patient and validate their concerns on their body as opposed to validating it on some remote site far away from them. I'm also struck by the fact that very often patients are heavily invested in getting a diagnosis. As an infectious disease specialist myself, it's not uncommon for patients to be admitted with an acute febrile illness, and it's often hard to convey to them that all these tests we're ordering, many of them are to determine what this is not. We're trying to identify the diagnosable, treatable, reversible conditions. And I often warn them that we may not actually find out what this is, and you're already going to get better before we know, if we know at all. And I think that uncertainty is as worrisome to them as it is to us. There's something in their narrative that remains missing. And so I think the challenge to us as we get better is not only to identify all these unknown entities, but also to allow the patient to thereby get closure on what was a very disruptive episode in their life. So in short, I will summarize my comments by saying, I think the measure of our diagnostic excellence has to be how well we do the simplest, most obvious things that are right before our eyes, but through inattention, through lack of training, through lack of skill, through busyness, we overlook them. And secondly, and leading into our next speaker, the diagnosis is important in more than just the classification of the disease. It's important to the patient in the embodied narrative of their particular experience of illness. Thank you so much.